Hello everyone, my name is Bhoomi Satani. I am internal medicine resident PGY2 at Texas Tech Health Science Center El Paso Transmountain. I am presenting clinical vignette Acute Epiploic Appendagitis, a hidden culprit behind left lower quadrant abdominal pain. I will begin with introduction. The epiploic appendages are approximately 1 to 2 cm thick and 0.5 to 5 cm long outpouching of the peritoneal fat attached to the antimesenteric surface of colon by vascular stalk, which contain veins and arteries. Epiploic appendagitis is an exceptionally rare condition, primarily resulting from ischemic infarction, which is most likely triggered by torsion of epiploic appendages. This torsion leads to obstruction of arteries and veins within vascular stalk. While epiploic appendagitis can potentially occur anywhere in the colon, it is most likely affect sigmoid colon and transverse colon due to their larger size and presence of numerous epiploic appendages. Risk factor includes obesity, strenuous exercise, hernia, Crohn's disease, and ulcerative colitis. Let's begin the case presentation. So we have a 51-year-old female presented to emergency room with a sudden onset of left lower quadrant abdominal pain. She described the pain as a constant, pressure-like, without radiation, and unaffected by bowel habits or eating patterns. Clinically, the patient appeared hemodynamically stable. Patient has a past medical history of Crohn's disease. On initial physical examination, patient had soft abdomen with tenderness in the left lower quadrant. There was no rebound tenderness guarding palpable mass. Patient had normal bowel sounds present. On imaging findings, a CT scan abdomen and pelvis with IV contrast revealed mesenteric fat stranding surrounding a fat density structure at the anterior aspect of distal descending colon and a small diverticulum in mid-descending colon. This finding indicate acute epiploic appendagitis adjacent to distal descending colon. In emergency room, the patient was administered oral NSAIDs and her pain was effectively managed after few hours. Upon re-examination, the patient demonstrated tolerance to a regular diet and remained afebrile with her pain well controlled. The patient was discharged home on same day with instruction to take ibuprofen as required. So this case illustrates the prompt and accurate diagnosis of epiploic appendagitis leads to optimal patient outcome and can avoid unnecessary hospitalization and antibiotic therapy, often misdiagnosed as acute uncomplicated diverticulitis. The mainstay of management involves conservative approach, including use of oral anti-inflammatory medication for a period of 4 to 6 days. If necessary, a short course of opioids for 4 to 7 days may also be considered. Surgical management should reserve for a patient who fails to improve with the conservative management and if the patient develops new or worsening symptoms or complications. Few learning points from this patient. First, rule out infection by laboratory data. Diagnosis of epiploic appendagitis by CT scan of abdomen and pelvis with contrast. This epiploic appendagitis is a self-limited condition. Treatment with NSAIDs and pain control. Avoid unnecessary hospitalization and antibiotic therapy.